Okay, so our next talk is Dr. Ali. He's from the Fred Hutch, and he's going to be speaking to us about MDS transplant approaches, which is the only curative intervention for MDS. So thank you.
Thank you, Dr. Scott. Let me pull up the slides. Good afternoon, and I hope that you are enjoying your discussion so far. I think it's going to be down here. This one. Yeah, great. Okay, so my name is Dr. Ali. I work here at the Fred Hutch, and I'm going to be talking to you about intensive treatment for MDS, which is stem cell transplantation. So I'm going to base my talk according to the questions that we get commonly asked when we see patients with MDS where stem cell transplantation is being considered. So first and foremost, who are the candidates for transplant? What is the best time for doing transplant in MDS? Who is eligible for transplant? The donor options, the intensity of transplant, and whether you need therapy other than transplant before or after stem cell transplant. So the first and foremost question is, what is a stem cell transplant? In a stem cell transplant, we take certain cells from a donor. These are called hematopoietic stem cells. I like to call them mother cells because these are the stem cells that will produce all the cells in your blood. What we are doing in stem cell transplantation is we are taking these stem cells from a donor and replacing it and giving it to the patient. And the idea that the defective cancer-causing bone marrow is replaced with a healthy new bone marrow. So overall, the goal of the stem cell transplantation is you want to improve the patient's blood counts. You want to eradicate the disease, MDS in this case, and then also provide a long-lasting remission. And that is why Dr. Bart Scott said that this could be a potentially curative therapy. So how does a stem cell transplant work? This is based on what's known as graft versus leukemia or tumor effect, where the immune cells from the donor called T lymphocytes, once they establish themselves in the recipient's body, they start to attack the cancer cells and destroy them. And that's called the graft versus leukemia or tumor effect. But also these very same T lymphocytes or immune cells also attack the normal healthy organs in the body of the recipient, and that can lead to a detrimental effect, which is known as graft versus host disease. So when we are considering a stem cell transplant for a patient, graft versus host disease is a very important factor that we keep in mind because it could potentially be a life-threatening complication after the transplant. So in MDS, broadly speaking, we have a higher risk MDS and a lower risk MDS, and I'll briefly touch upon this, although this has been reviewed extensively in earlier talks. For higher risk MDS, we offer transplantation upfront, meaning a patient who gets diagnosed with a higher risk MDS, those patients would be candidates for an upfront allogeneic transplant. Or if they didn't receive upfront transplant and received non-transplant therapies, we offer transplant after failure of the initial hypomethylating agents. In the lower risk MDS, we offer transplant only after failure of hypomethylating agents, or if the lower risk MDS progresses to a high risk MDS or secondary AML, or if their counts remain really poor despite therapy. So how we categorize MDS, this is on the basis of a variety of factors that I've shown here. So when a patient is diagnosed with MDS, we look at all these factors and come up with risk stratification. So patients are going to have poor blood counts because of the MDS. All the patients get a bone marrow biopsy, and the pathologist looks at the bone marrow biopsy under the microscope and gives a pathological classification, and different pathological classifications have different risk factors. Also, very importantly, we look at what we call blasts, and these are these big cells shown here. Blast cells are essentially synonymous to cancer cell or leukemia cell or MDS cells, and the percentage of this is very important. But also, we look at the chromosomal abnormalities that are seen in MDS. And now, very importantly, we look at the mutations within these chromosomes And once a patient gets diagnosed with MDS, all of this information is available to the physician, and they will put it into these various scoring systems and come up with a scoring system that can tell if you have a low risk MDS or a high risk MDS. So this has been reviewed extensively. I'll briefly touch upon it. The first of these scoring system was developed in 1997. It's called International Prognostic Scoring System. It incorporated the percentage of blast, the blood counts, and the cytogenetic or chromosomal abnormalities. But over the years, there have been several editions of this, and the most recent one is something called Molecular International Prognostic Scoring System, which looks at all of these factors, but importantly, mutations, the number and type of mutations, which the previous versions have not looked into. So briefly, one of the most commonly used scoring system is what's called IPSS revised. It includes chromosomal or cytogenetic abnormalities, the percentage of the blast in the bone marrow, and the blood counts. You'll notice here that not all cytogenetic abnormalities are the same, because in this table, there are some abnormalities that could potentially be, not that having MDS is good, but within the spectrum of MDS, there are some abnormalities that could be constituted as very good or good, but there are many others that are bad and very bad. So once you have all this information, you have one of these 5 categories ranging from very low to very high based on the score. And then you can see that the survival is very different here on the graph shown on the right. Now, like my colleagues, I'm going to be showing some curves like these. And just to give you a basic idea of what this is something called Kaplan-Meier curve, where we plot survival over time. So on the horizontal axis right here is time, and then the percentage of patients who are surviving over time is kind of shown on this. So you start off with a 100% patient population, and then over time, as patients die, the curve sort of drops. But what's important here is you want to look at the slope or the steepness of the drop in the curve. So for example, in this scenario, the very low risk group can survive even a decade. And if you look at the very high group, the drop in the curve is very steep. So recognizing that there are a lot of genetic abnormalities, I'm showing you this not to kind of go over the individual mutations that we see in MDS, but to show the wide breadth of abnormalities in different genes that we see in MDS. Not only that, the number and type of mutations are very important. In this study, which was done in about 800 patients who underwent stem cell transplant with an unrelated donor. And these are the patients who had MDS, MPN, or secondary AML. They had blood samples taken before their transplant, and then this was later on analyzed to see how these mutations affected the prognosis. And here you see that the number of mutation matter. If you have 3 or more mutations, your survival drops. But also the type of mutation is very, very important as well. And you have heard about the TP53 mutation, which is one of the most aggressive mutations in not only MDS, but many other types of cancers. So this is probably the 4th time you're seeing this slide, but again, highlights the importance of all these scoring systems and mutations, because this is what's critical in making decision making. So this is the latest version of the IPSS, where these mutations are incorporated, and you can range from a very low risk to a very high risk, and the curves are shown on the right. So using the scoring system, you can have a lower risk MDS, which are listed here, or a higher risk MDS. Now, unfortunately, transplant is not an option for all the patients, or not considered, I should say, in all the patients. The common reasons for that, not everyone has a donor, or I should rather say a suitable donor available. Not everyone is fit to undergo an intensive procedure like stem cell transplant. And then transplantation may also fail, because even though we're doing the stem cell transplantation to potentially cure patients, but approximately 30 to 70% patients may have a disease relapse. But then there are other reasons that transplant may fail, including infections after the transplant, graft versus host disease, and damage to the internal organ. When it comes to lower risk MDS, we currently do not offer stem cell transplantation for lower risk MDS. And this is based on these two retrospective studies. The first one on the left looked at patients with MDS and AML, and they were younger than age of 60. And they received an intensive type of transplant called myeloablative transplant, which I'll review in the next slides. Here, if you look closely, the top panel here is the group that did not receive the transplant, and the bottom panel is where patients receive transplant. So if you look closely for the low and intermediate risk patients, you see that the steepness here is much more flatter here with non-transplant strategies, but it drops pretty dramatically, at least in the early part, and that is because of the mortality, early mortality that is associated with stem cell transplant. Similarly, on the right, if you look at the lower or intermediate one risk category, now these are the patients who are over the age of 60 and they receive reduced intensity transplant. Again, non-transplant therapies performed better compared to transplant. So currently, we don't offer stem cell transplantation for low risk MDS, and delaying transplant until their disease progresses is associated with better prognosis, better survival. So the optimal timing of the transplant, you don't want to do it too early because that is associated with a higher mortality from the transplant. But also the flip side is if you do it too late, particularly, for example, when patients have leukemic transformation or secondary AML, it is known that the outcomes could be inferior in those cases as well. Now, this is not to say that we don't offer stem cell transplant for patients who progress. We certainly do, but the outcomes may be inferior compared to doing a transplant at a relatively earlier stage. So switching gears a little bit, what about upfront transplantation for higher risk MDS? And I'm going to briefly review the 3 clinical trials that have answered this question. So the first of these was published in 2015. It looked at patients with MDS between the age of 50 and 70. And patients who had donor, 10 out of 10 sibling or unrelated donor proceeded on to transplant, and the other group continued with other therapy, mainly hypomethylating agents. So if you look at the curves here, now what's important to note here is that these curves are very close to each other, and they don't start to separate until about 2.5 years or so, which means that there is early mortality because of the transplant, but in the long run, in this case, about 40% of the patients will have long-term remission and potentially cure from this compared to non-transplant. So the benefit of the transplant, you're not gonna be able to see it really early. It's usually after 2 years or so when you start to see the difference. Similarly, there was another European trial called Videza Allo clinical trial. And again, the idea was similar, patients with MDS, CMML, and they also included some patients with secondary AML. And these patients were between the age of 55 and 70. These patients received azacitidine initially, and after 4 cycles, if they had a response to azacitidine or had stable disease, and if they had a donor available, they proceeded to transplant, and the other group who did not have donor just continued with azacitidine. And again, the same thing, you'll notice here that there is early mortality because of the transplant, and the curves, in this case, actually inferior. But in the long run, after about 2.5 years or so, you start to really see the separation of the curve, and about 40 to 50% patient in this case are potentially cured from transplant. And then the last one, which is the biggest of these trials, is the US clinical trial, BMT-CTN, what's also called biologic assignment clinical trial. Same MDS patients, they were between the age of 50 and 75, and they received 8 out of 8 sibling or unrelated donor reduced intensity transplant if they had a donor. And then the no donor or those who did not have a donor just continued with either hypomethylating agents or best supportive care. So same thing in the early phase of the post-transplant period, you don't see the separation of the curve, and it's later on when you really start to see the benefit. On the right-hand side, I'm showing you what's called a forest plot, which looks at different subtypes of MDS in this particular clinical trial and whether transplant was beneficial in those individual subgroups or not. Now, you want to focus on these blue squares. If this blue square is to the right of this vertical line, it means transplant is better. And if it's to this side, then non-transplant is better. And you can see of all these age groups, based on the age, based on whether they've had response to treatment before and their IPSS category, all of these subtypes have a beneficial effect with the transplant. Unfortunately, not all patients are candidate for transplant, and historically, age has been considered to be one of the limiting factor, and that is because of high risk of death that can happen in older patients with transplantation. There are also issues with healthcare resource utilization. However, in the last 2.5 decades, we have had significant improvement in terms of how we design what we call conditioning regimen, which I'll review in the next few slides, and improved supportive care during the transplantation, where we are now able to take patients even in their 70s to transplant. You obviously have to carefully select those patients. Now, the idea is stemming from this retrospective study where you can see these patients are, based on different age groups, are having pretty similar outcomes after the transplant. So age is not really a factor here. But there was also a prospective observational study done by the CIBMTR where patients over the age of 65 were enrolled, and there were about 688 patients enrolled in this study. And they were compared to a younger contemporary cohort between the age of 55 and 64. And you can see that really there's no difference with regard to transplant-related mortality or overall survival. So age alone is not contraindication to transplant. But the question is, how do we assess the fitness for the transplant? And this is one of the tools that we use is another scoring system. We use our scoring systems in medicine, and particularly in oncology. This is called Transplant Comorbidity Index, which looks at various comorbidities that the patients may have and comes up with a scoring system that can tell the potential mortality that could be associated with transplant. And this was a graph taken from a study conducted by Dr. Sorer, actually here at the Fred Hutch, which showed that if you have score of 3 or higher, that portends higher risk of mortality due to transplant. So in summary, it's the physiological age and the performance status that is much more relevant when we are selecting patients for transplants rather than the chronological age. So switching gears a little bit, talking about how we select the donors. And firstly, I'm going to review what's called human leukocyte engine, or HLA system. This essentially defines your immune system. It's an immune signature. It is located on the 6th pair of the chromosome. You may recall from your biology class, you have 23 pairs of chromosomes. So on the 6th chromosome, you have these genes. And we essentially look at 10 or 12 genes, or 5 or 6 pairs of these. And you have, in this example, you have 4 possibilities of these pairing. So if you look at the siblings, there's about 25% chance that a sibling could be an identical match with you. But many patients may not have sibling donors, and we look in the registry where you may have a fully matched donor in the registry. Now, recently, there's been an increase in what we call haploidentical, or a single match, where one of these 2 chromosomes is matching. And by definition, parents and children are haploidentical to you. And then lastly, we also have option of umbilical cord transplant. So in this example, if you have this patient who needs a transplant, sibling 1 has 3 siblings. Sibling 1 is fully matched with the patient. Sibling 3 is not a match at all. And sibling 2 is half matched because it's sharing 1 copy. And then also the parents of this patient they're also haploidentical. So what is the likelihood of finding a donor? And this was done in this study, which was published a few years ago, looking at US population patients who self-identified into one of these racial and ethnic groups. Now, the study showed that for Caucasian patients with European descent, there was 75% likelihood that they had a 8 out of 8 HLA match. But if you included the mismatches, 1 mismatch, 7 out of 8, then the likelihood was pretty much close to 100. On the other hand, unfortunately, for African Americans, for African and Black Caribbeans, the likelihood of finding a fully matched donor is very less, one of the lowest, less than 20%. So what are the other options if you don't have a fully matched sibling donor and unrelated donor. The two options that I briefly reviewed are haploidentical donor and umbilical cord blood transplants. So this is a slide taken from the CIBMTR registry, and the real purpose here to show you is this blue line right here, which is the haploidentical transplant. And you will notice that in the last decade or so, the numbers have grown substantially, and we are now performing more and more of these haploidentical transplant, including in MDS. So if you don't have a fully matched sibling or unrelated donor available, which of the two is better, haploidentical or umbilical cord blood? And this was studied in this clinical trial, a randomized clinical trial. It did not include MDS patients, but the principle applies. Had patients with acute leukemia and lymphoma, and they had both umbilical cord units as well as haploidentical donors, and they were randomized to receive one or the other. This study showed that patients with umbilical cord transplant had a higher mortality, primarily because of infections and other transplant-related complications that are more common in umbilical cord than haploidentical. So the result of this study was that haploidentical would be favored over umbilical cord. So in Seattle, this is our sort of workflow. We try to see if there's any suitable identical sibling donor. If that is not the case, then we look in the registry. And if that is not available, then the three options are haploidentical, umbilical cord, or even in some cases, mismatch transplants. So what does the process look like for transplant? The transplantation incorporates essentially three things. The first, which also defines the intensity of transplant, is something called conditioning regimen, also known as preparative regimen. And as the name suggests, it prepares the patients to receive the donor stem cells. So it is basically chemotherapy with or without radiation. And the purpose of this is to, number one, eradicate MDS cancer cells, but very importantly, also suppress the immune system of the recipient so the donor stem cells can easily grow in the body of the recipients. In other words, preventing rejection of the graft. A common analogy I like to give is de-weeding the garden before you plant the new seeds. After you get the conditioning regimen, now you're ready to receive the infusion of the stem cells. But then also the third thing that is also part of the transplant treatment plan is something called graft versus host disease prevention. As I mentioned in the few slides earlier, that one of the complications is graft versus host disease despite best of the matches. And we want to use 2 to 3 different immunosuppressive or anti-rejection drugs to prevent these complications. What about intensity of the transplant, or in other words, intensity of the conditioning regimen? And this plot right here basically gives you all the different types of conditioning regimens that are available. Again, without going into those individual regimens, the key message here is that as you increase the intensity, you are increasing toxicity. Now, increasing the intensity, as I'll show in the next few slides, is beneficial with regard to decreasing relapse risks. But unfortunately, not everyone is going to be eligible to get an intense regimen. So there are some regimens that have developed that are falling in the reduced intensity category. And when you are using reduced intensity category, you're relying more and more on this immunological mechanism to fight the cancer, the graft versus leukemia effect. So the key question here is, does the conditioning intensity matter? And this is actually a study that Dr. Scott did a few years ago, which looked at 2 groups. These are patients with AML and MDS between the age of 18 and 65. And they received related or unrelated donor transplants. And about 135 patients received myeloablative conditioning regimen, and 137 patients received reduced intensity regimen. If you look at the curves here, the blue color curve is the myeloablative regimen, and the reduced intensity shown by yellow. So you can see that there is a difference. Now, this initial analysis looked at patients about 1.5 years out from the transplant. It did not show what we call a significant difference, even though you can see the separation of the curve. So there was a longer follow-up after 4 years, which clearly showed a benefit of the myeloablative regimen compared to the reduced intensity regimen. Another very important question is, can myeloablative regimen clear the mutations, which are really the driving force of these cancers, right? So the same clinical trial there were about 95 patients with AML, and they had blood samples taken before transplant, and there was a DNA sequencing performed to look at these genetic mutations. Now, in this study here, the curves basically show that patients who had mutations still present before transplant, they were more likely to be cleared by myeloablative regimens compared to reduced intensity, which is kind of shown in this dotted purple line. And you can see the clear difference between the two groups. So moving on, what about therapy before the transplant? It is known that if you have lower burden of the disease, and by burden of disease, I am referring to the percentage of the blast that I show you in the earlier slide, particularly if the blast percentage is more than 5% and really after more than 10%, we want to bring it down to less than 5%, something called cytoreduction. And this is generally done by two types of therapies. The first one is the intensive chemotherapy. Many of these patients, particularly if they have more than 10% blast, would get intensive chemotherapy to bring this level of the blast count down to less than 5%. But many patients will receive hypomethylating agents. Current standard of care is that if you have more than 5% blasts, then you want to really get it down to less than 5% of blast to give you the maximum benefit from the transplant. There haven't been any prospective clinical trials to date, except for one that actually Dr. Scott did. I don't think the results are out yet, but Dr. Scott can correct me if I'm wrong, which looked at the type of therapy which would be beneficial, either hypomethylating agent or a chemotherapy. In general, when we see patients and they have lots of blasts in their bone marrow and they are eligible to get stronger chemotherapy regimens, we would offer them a stronger chemotherapy to get rid of those blasts before moving on with the transplant. And these are the curves that are sort of showing that there was no real difference between whether you received therapy before transplant or not. But again, there are several caveats to interpretation of these because some of these are these are retrospective studies, and there's a lot of what we call selection bias in these studies. What about therapy after the transplant? Well, this sounds really counterintuitive to the whole idea of the stem cell transplant because we are doing the transplant to cure the patient. Unfortunately, so the question is why you need more therapy after the transplant. And the answer is not straightforward. Unfortunately, 30 to 70% of the patients with MDS will eventually relapse. The highest risk of relapse is in the first 2 years. So we use various risk stratification for patients who have a higher risk of relapse after the transplant, and we would offer them maintenance therapy after the transplant. It comes with obviously a lot of challenges. The main challenges I've listed here are the risk of cytopenias or low blood count and infection that can happen because of these therapies in the post-transplant setting. But also they can injure the internal organ, and if patients have graft versus host disease going on that requires treatment of its own, then it gets really challenging to give them these therapies while there is an active graft versus host disease going on. Nonetheless, it is something that we discuss with patients and carefully select patients who would be eligible or who could potentially benefit from maintenance therapies. And the most common agents are hypomethylating agents, azacitidine or decitabine that you've heard quite a bit today. But then there are some investigational agents as well. For example, venetoclax and drugs that target specific mutations, for example, FLT3 mutation and IDH mutations. And these are currently in the investigational stage. Lastly, I'm going to talk about two specific types of MDS, which are, I think, very important and deserve special mention here. The first one is what we call therapy-related MDS. And this is development of MDS that occurs in patients who have received either chemotherapy or radiation in the past for treatment of other cancer or non-cancerous disorders. It is estimated that about 7 to 12% of all the MDS cases are therapy-related. And they have really poor prognosis because there is a higher likelihood of having bad chromosomal abnormalities, including TP53 mutation in therapy-related MDS. So currently, and the other challenge with this is that most of the clinical trials will exclude these patients when we're evaluating the role of transplantation. So for patients who are otherwise candidates for transplant with regard to therapy-related MDS, we will offer them. This is a retrospective study from the CIBMTR that looked at 5-year overall survival for therapy-related MDS, and you can see that there was about 27%. So this is obviously much lower than otherwise that we would see in MDS. And then lastly, about MDS with TP53 mutation. It's a unique subtype, carries a very poor prognosis. This graph on the left is showing patients who underwent transplantation, and this is comparing patients who had TP53 mutations with those who did not. And you clearly see that there is a big difference. Looking at these curves, one might argue why offer transplantation such a high intensive therapy to patients who have TP53 mutation. But then not all TP53 mutations are MDS patients carry equal prognosis. In fact, in this, again, another retrospective study, there could actually be some patients with TP53 mutation which may have who may have a better prognosis. In this study, it turned out that the transplant comorbidity score, the performance status, and the status of the disease at the time of transplant would also further risk stratify these TP53 mutation. And then most importantly, the clinical trial that looked at the biologic assignment trial actually looked specifically at this mutation in patients with MDS. And here, comparing non-transplant option, yes, the outcomes are overall not good for patients who receive transplant, but in comparison to the no transplant group, you still see some benefit here, which again means that there are some patients with TP53 mutation who could still be candidate for transplant. So transplant is a very complex process, requires a complex decision, multidimensional approach to this. And there are a lot of factors that I've briefly touched upon here that will determine if a patient is a candidate for allogeneic transplantation or not. But most importantly, it is shared decision-making. Patients and also their caregivers need to be educated enough. They obviously will have input from the physician, but it's a partnership with the goal of patient-centric goals in mind and making this decision. And this is where conferences like these come in extremely handy. So I think this is my last slide. I thank you all for your attention and happy to take questions.
Thank you very much. That was an excellent talk. So do we have any questions for Dr. Ali that has to deal with MDS and transplantation? No? Okay. What is the upper age limit for transplant? You say age is a consideration, but is there an upper age limit where you would say, no, we should definitely not do this?
Yeah, this is, so I would say that anyone over the age of 65 should get transplantation consultation. In our center, I think Dr. Salat was mentioning a patient 78 years old who received the transplantation, and very commonly we would see patients in their mid-70s getting transplant. So I would say if you're in your 70s and you're otherwise have a good performance status, then you should have a transplantation consultation because you could be a candidate for transplant.
All right. Thank you.
Thank you.
Appreciate it.